things that will give you a clue if the patient has bacterial infection is the sputum will be purulent. The sputum will be purulent. If the sputum is purulent, then you want to check the procalcitonin. The procalcitonin is usually produced by neutrophils. Procalcitonin is usually produced by neutrophils. So when the level is elevated, you know the patient has some bacterial infection. So when they develop purulence, you also need to check the procalcitonin. Some patients who have purulent sputum, you may not be able to get enough specimen, but the procalcitonin can help you determine if they have bacterial infection or not. Theophylline is usually not recommended during exacerbation because the contribution is not that significant in terms of bronchodilation. Now, if you're going to use phosphodiesterase inhibitor, roflumilast, remember we said the patient has to have chronic bronchitis. Leukotriene modifiers have not been shown to be helpful, so they're currently not available for use. And these are some of the agents we use in stable COPD. The patient can use albuterol. If it's stable, you can use PRN as needed. And this can be in addition to the long-acting LAB. Can be in addition to the long-acting LAB. Okay, so what is Atrovent? Okay, make sure you know brand names. Atrovent is protropium. Okay, that's a short-acting agent. Okay. So it says Convivent, protropium, albuterol. Now, if the patient is getting let my marker in the glass. If the patient is getting a nebulizer, the brand name is going to be Duoneb, D-O-N-E-B, D-O-N-E-B, Duoneb. Duo means two, nebulizer. So you're going to get the same thing, but in this case, getting a nebulizer.
You said you give it with a nebulizer, it's Duoneb?
Yes. Okay, so budesonide basically when it's combined with formoterol, usually will be twice daily. Because again, with this formoterol, usually will be twice daily. The same with fluticasone, depending on the beta-2 agonist is combined with. So when it's combined with salmeterol as I've heard, usually dosing, 12 hours apart. So So these are some other formulations, indicador, tiotropium, roflumilast. Again, just keep re-emphasizing roflumilast. Usually it doesn't have a bronchodilator effect, it's more anti-inflammatory. And usually patients should also have a diagnosis of chronic bronchitis. Another basically two long-acting agents, anticholinergic and beta-2 agonist. Kyoto, again, same thing, anticholinergic or muscle antagonist and long-acting beta agonist. Okay, so this is a case. The chief complaint, my wife said I need to get my lungs checked. Ever since we moved, I'm having a hard time breathing. HPI, Morris is a 59-year-old man presenting to a new provider at a family medicine clinic today with complaints of increasing shortness of breath. So that's the most common complaint this patient we have, increasing shortness of breath. And remember I said a patient with heart failure can also have increased shortness of breath. A patient with pneumonia can also have increased shortness of breath. So X-ray in this case can help you to rule out or rule in heart failure, can also help you to rule in or rule out pneumonia. Okay. He points out that he first noticed some difficulty catching his breath as a job 3 years ago. He has been able to carry heavy loads up and down the flight of stairs daily for the past 35 years without problem. However, shortness of breath began to make this very difficult. Coincidentally, at that time, he accepted a managerial position at his company that significantly reduced his activity level. After taking this position, he no longer noticed any problems that means that he avoids activities that cause him to physically exert himself. He noticed significant shortness of breath again after he moved to Colorado from a lower elevation 2 months ago to be closer to his grandchildren. He maintained this same managerial position with the move and does not physically exert himself at work. His previous position had placed him on budesonide, Motorola, Silicate, to inhalation twice daily 2 years ago. He thinks his physician initiated a medication for shortness of breath, but he's not entirely sure. He's hoping to get a good medication that will help relieve his shortness of breath because the gardening season is right around the corner and he enjoys this hobby. This is past medical history, CAD, MI 7 years ago, resulting in placement, stent placement, chronic bronchitis, cervical radiculopathy, and these are the medications. If we look at the medication, we see that bupropion, SR 150. What comes to your mind based on the history we have in the so far? Smoking cessation. Okay. So these are the medications listed there. etiology, non-drug allergy, family history, father alive with COPD, smoke a pipe for 40 years, mother alive with CAD and cerebrovascular disease. Social history, he lives with his wife, who's a nurse. He has a 45-year history of smoking. When he had an eye at age 52, he quit smoking temporarily. At present, he continues to smoke. Again, that's a problem. The other thing that can follow the progression of the disease is smoking cessation. As long as they keep smoking, you give them medication, you just try to control the symptoms. No medication is going to control the progression of the disease. So that's why smoking cessation is very important. He drinks 2 beers most nights of the week, work week, and 2 of the 3 glasses of wine on the weekends. Review assistant, positive chronic cough, speeding production, positive exercise intolerance. General is well-developed, well-nourished man in acute distress. No acute distress. Vital signs given. AT&T, pneumocephalic, basically normal exam. Neck exam, normal lungs. Decreased breath sounds. No rouse from crackles. Cardiovascular, regular rhythm reading, no murmurs. Normal S1, S2. Abdomen soft, non-tender, non-distended, positive valve sound. No organomegaly. Okay, in some patients with moderate to severe disease, abdominal exam may also show a barrel chest. Abdominal exam may also show a barrel chest, which tells you there's a lot of air in the lungs. That's why it's barrel chest. G erectile, that's normal. Extremities, no clogging, cyanosis, edema, 2+ pulses throughout. Neural exam is also normal. The labs, basically labs look okay. Now, look at the pulmonary function test. Look at the pulmonary function test. How do we determine if a patient has COPD? Okay, so let's do that and see. So it's less than 70%. So this tells you the patient has restrictive airway disease. It doesn't tell you the severity. Do you have information there that you can use to determine the severity?
He said something about
FEV1 divided by FVC tells you they have what? COPD. What about the severity of the disease? What do we do?
FEV1 only.
Yeah.
FEV1 only.
So do you have any information here that can tell you whether it's mild, moderate, severe, or very severe?
You don't have like the percent?
Huh?
Moderate.
Moderate?
Yeah.
How do
Well,
you
he's
determine?
asking what is telling you that.
Because it's 50 to 70.
Do we divide the regular by the predicted?
Exactly, we do that, let's see.
It's gonna be 0.74, it's gonna be mild.
Okay, so you just do, okay.
So
So
mild
we have
is,
it.
mild is 80 or more.
2.7.
Mild is 80 or more.
3.7.
50 60 to 79 will be what?
Moderate.
So this patient falls in there. Okay. So that's basically what I wanted to show you. How to make that determination.
Can you go back again? So we use the predicted value.
Can you hear you?
We use the predicted value and the
Divide
actual value for
the actual versus the predicted, yes.
Mhm.
You divide this by
by
the
the
predicted.
actual
You divided 2.75 by the predicted.
Okay.
So you use that to determine the severity.
0.74.
So in this case, the patient has moderate.
So do you always give the predicted FEV1 as well to
Yeah,
determine
well,
the severity?
both come together.
Okay.
Okay, so assessment, this is a normal appearing 59-year-old man presenting to the clinic with complaints of shortness of breath that is limiting his activity and affecting his quality of life. Given the results of the spirometry, and patient history, patient has COPD, and we know the patient has CAD and cervical reticulopathy from the history. So based on what I just showed you, FEV1, FEVC, that tells you the patient has COPD. That's right. So the plan will be to relieve the COPD symptoms, prevent lung disease progression. How are you going to do that? Get into smoking cessation first. Again, medication is not going to prevent disease progression. You need to stop whatever is causing that disease. In this case, smoking, working environment, you get involved in a lot of dust, chemicals, so they need to avoid those activities. But the most common cause will be smoking. 90% will be due to smoking. If you go to the VA, you see a lot of patients who have COPD. A lot of them. Okay. So they have to improve exercise tolerance, treat and prevent acute exacerbation, improve quality of life. Improve quality of life also involves improving exercise tolerance. This is a man who wants to be engaged with his grandchildren, so that would be important. In addition to smoking cessation. Of course, it's not a good thing to be smoking around your children. I don't know about you, but for me, don't smoke around your children. Okay. Non-drug therapy. Smoking cessation. You also see patients getting nicotine, the different types of nicotine patch, nicotine options. We also need to know the Gold ABC toolkit. That will tell you where to place the patient in terms of treatment. And these are some of the nicotine replacement therapy. I don't expect you to know this for the exam, but just general information. Again, nicotine replacement therapy. So we saw this patient getting bupropion. So that's part of the smoking cessation therapy. Varenicline is also available. So because of the adverse effect profile, clinicians probably want to start with the patient with bupropion. Okay, I think that's the end of this lecture. Any questions?
AOC.
I've been telling you, I've been emphasizing what you I don't believe in you, but I've been emphasizing what you Okay. Yes,
Oh, Dr. Abobo,
yes.
have we settled the 405 versus 400?
What's that?
The overall grade.
For GI.
405 versus 400?
Yeah.
Dr. Yosemite put it as 5 at the bottom, that's.
Okay, I already posted your, I already submitted your grade.
Huh? It's on our transcript.
You go to the transcript? Now, what are the,
We haven't settled the point.
what are the,
What's happening?
I was so lenient. I was so lenient.
Really? We love you. Go
Very
ahead.
lenient.
This semester?
Now, we have some students who are C minus. Those students need to do remediation before the end of the semester.
So that means you haven't posted the grade.
What, did you update them in Blackboard?
The grades, I didn't post the letter grade on Blackboard. The letter grade has been submitted.
It's on our transcript?
It should, if I already submitted it yesterday. Yesterday was the deadline.
Will it change or will it?
Yeah, but it's been submitted. Now, some students, I think about 7 students did not pass.
CPT.
7 students, yes.